Good afternoon, everyone. Welcome to today's session, Nursing Series, courtesy of Nursing Standards, KNH. We are glad to have you on board this session today, and we are happy that you have found time to join. I can see so far we are quite a number, and we allow a few more minutes, like 4 minutes for those who are still joining, so that they're able to start off with us. Today we have a very interesting topic, and for the past seasons in nursing series, we have been handling more of nursing practice. But today we shift focus and we venture into nursing research. That is where we are heading to for today. So it's going to be quite a shift of our mindset from nursing practice and now heading to nursing research. So we are allowing just like 3 more minutes by 2:10, 10 minutes past 2. We will continue. Just 1 hour and 30 minutes of investment of your time into building our own capacity, our knowledge base. And this time we are doing it through research, a very important component in nursing. Good. I see the quorum is good enough for us to continue. So allow me this time to introduce myself. My name is Ruth Nyansikera from Nursing Standards, Education, Research and Innovation in KNH, simply known as Nursing Standards within Kenya International Hospital. And I am joined here with the presenters for today. The main presenter is one Rosemary Mudhoni Dhaiya. Rosemary Mudhoni is a principal nursing officer who works in KNH, and she has adequate experience, not just in nursing practice, but also in nursing research. And she works in Ward 4A, that's a pediatric surgical ward. Therefore, today's topic is as evidence from the ground, from the pediatric patients that we have within the institution. Now, Rosemary is a nurse who holds a Master of Science in Nursing, in Critical Care Nursing. And as I mentioned earlier, she has over 30 years experience. And Rosemary is currently pursuing a PhD in nursing, and we look forward to the end of this program. So for today, we are privileged to have her on board, ready to share the research findings from the study that was done within KNH in this institution. Alongside Rosemary is one of our senior colleagues. She's Madam Sharon Okeo, the Senior Principal Nursing Officer, Surgical Specialized Surgery. She's here, and she's fairly like our host, because this is the stuff that is happening within her environment. And we are happy to have her join us and just be with us in this session. So I will go ahead to let us know that we are welcome. Any questions that we may have, any contributions that we'd like to make, there will be time for that. In the first session of this, in the first part of this session, we will have our presenter take us through the research. And then we will allow time for questions and answers and discussions at the end of this presentation. So should you have not something that you'd like to comment, kindly note it down, and then we can discuss it at the end. So at this juncture, it's my privilege to welcome Rosemary so that she will share the findings of these studies. A very interesting topic. I looked at this topic and the topic says experiences of caregivers of neonates born with gastroschisis in the neonatal intensive care unit at KNH. Yes, it's a phenomenological qualitative study. Shift again from the patient to the caregiver to the patient. A very unique dimension of looking at care provision. Rosemary, karibu, and pick it up from there.
Thank you, and you're most welcome as we share the findings on the experience of caregivers of neonates born with gastroschisis in KNH. I want to give my acknowledgement to the Almighty God for the favor and the grace to carry out this research. I also thank my family for the support they gave. My supervisors, Dr. Sarah Bett and Dr. Grace Gashweli from Kenyatta University for their support and supervision. Dr. Joel Lesan, who was by then the head of specialized surgery department by the time I was carrying out my research. Mrs. Talam and Mrs. Sharon Okeo, they were the senior principal nursing officer in the Department of Specialized Surgery during the time I did my research, and they gave me a lot of support. The nurses in Ward 4A, especially the NICU, they were very supportive. The nursing standards, KNH, for giving me a forum to disseminate my research findings in this preparation and also in the preparation. I want to take us to the background of gastroschisis. It is a rare congenital condition that results in the protrusion of the abdominal contents, that is small and large intestines and the stomach. It occurs in the early stages of development due to rupture of the amniotic membranes. This is according to Antonio et al. That was 2015. Globally, the incident is 1 birth into 2,000 live births. As per Wesonga, that was in 2016. And the preference is approximately 3 per 10,000 live births and increases globally with a 6% rise every 2 years for reasons unknown. It has a high mortality ranging from 33% to 100 across sub-Saharan Africa, and with modern treatment, that is in neonatal intensive care and prompt pediatric surgery, survival rate can exceed to 90%, and that is in high-income countries. This is according to ECO 2019 and Wright 2015. Survival by the time I was doing my research was 99.1 in the US and 45.3 in Kenya, according to Anderson et al. 2022. In Kenya, it is one of the major causes for surgical intervention for neonates with a rate of 26.6%. The problem statement is that neonatal mortality from gastroschisis in sub-Saharan Africa is high, while in high-income countries, mortality is less than 5%. Neonates, most of the time neonates will get to the hospital after long exposure, leading to dehydration, hypothermia, and sepsis. With immediate medical response. So immediate medical response is required due to vulnerability in neonates. So gastroschisis is associated also with high cost of treatment, and there is low care. The overall quality of the life of caregivers is somehow very low. The admission to the ICU also comes with its own challenges. There is prolonged hospitalization, which could lead to financial constraints, emotional draining, leading to depression. So support for caregivers is an important factor for positive outcome. Some of the supportive care strategy from literature includes knowledge sharing on the care of neonates with gastroschisis, raising awareness of the condition, and having peer support groups for caregivers to lobby for the condition and raising caregivers' knowledge of gastroschisis. Most of the studies that have been conducted on gastroschisis globally and in Kenya have been quantitative, and therefore I saw the need of therefore inadequate documented information on the condition and the experiences of the mothers of these neonates is not known. So gastroschisis is an important congenital malformation with impact not only for the affected infants, but their families too. The experiences of their caregivers are unknown. Therefore, there was need to conduct a qualitative research that details the experiences of mothers whose neonates are diagnosed with the condition to inform of the care and support needed for this population. The objectives, my broad objective was to describe the experiences of caregivers whose neonates are born with gastroschisis and are admitted in neonatal intensive care unit. Specific objectives are to describe the prenatal and postnatal experiences of caregivers whose neonates are diagnosed with gastroschisis and are admitted in NICU, that is in Kenyatta National Hospital. Another specific objective was to explore the nature of trauma symptoms exhibited by caregivers whose neonates are admitted in NICU in KNH with gastroschisis. And the third one was to explore the support needed by caregivers whose neonates are diagnosed with gastroschisis. My inclusion and exclusion criteria, I included the mothers of neonates diagnosed with gastroschisis admitted at KNH Ward 4A NICU for at least 2 weeks. Then the exclusion, mothers who have been in the ward for less than 2 weeks, for they may not have had enough experience with the phenomena of my interest. The mothers also with cognitive impairments who may not have the requisite capacity to give informed consent. The methodology, the study designed was descriptive phenomenology qualitative study, and the study site is Kenyatta National Hospital, Intensive Care Unit, Ward 4A NICU. My study population was caregivers of neonates diagnosed with gastroschisis in KNH NICU, that is Ward 4A. My sample size, I used 25 caregivers with neonates born with gastroschisis. The sample size in phenomenology studies ranges from 5 to 10 participants. Then the sampling method, I used purposive, that is all respondents with the required phenomenon of interest admitted in the ward during the time of the study were approached and included in the study. The data correction tools, I used an interview guide to correct data, and a tape recorder was used to record the interviews. Data correction process. A research process was explained to the respondent and consent was obtained. The researcher conducted individualized in-depth interviews with respondents to capture information on concepts of interest on their lived experiences as caregivers of neonates with gastroschisis. The in-depth interview were audio recorded to ensure accuracy of information was captured. The captured information on experiences were also recorded in a journal for ease of reference during data analysis. This ensured that the information analyzed is the real experience as narrated by the participants. I sought for ethical approval from Kenyatta University, NACOSTI, Kenyatta National Hospital, and also informed consent from my respondents. Data analysis, I used the MATEC analysis, whereby transcribed data was retrieved from the recorder and analyzed manually. Then the transcribed verbatim data was coded. Data then was inductively developed into themes and sub-themes. My findings, I had the characteristics of the caregiver where I'm referring as N to 25. The average age of caregivers was 26 years, with a range of 20 to 36 years. The average age of my neonates were 15 days, with a range of 14 to 16 days. The average birth weight was 2.6 kgs, with a range of 2.4 to 2.8 kgs. The issue of employment, 8 of the caregivers were employed, and the average income was 32,500 per month. First time delivery, I had 12 caregivers. Married, there were 21 caregivers. For the educational level, we had 9 of them who had primary level of education. With the secondary, we had 10, and I had 6 with the university level of education. Then among the respondents, prenatal ultrasound, 6 of them had had an ultrasound done during their prenatal period, of which among the 6, only 1 of them was diagnosed. So 5 were not diagnosed. That means the gastroschisis was not detected. Then 19 did not have an ultrasound. So pre and postnatal experiences as per my objective 1, which was to describe the prenatal and postnatal experiences of caregivers whose neonates are diagnosed with gastroschisis and are admitted in NICU. I came up with the theme and the sub-theme and the meaning from the clients. And the one of the theme that came out was that the normal pregnancy is a theme. The sub-theme is that most of the mothers, they expressed happiness and they were excited when they realized that they had conceived and they were expectant. So as I can quote one of them, F10 said, I was excited because I wanted to have a baby. Then another sub-theme from the normal pregnancy was the antenatal attendance. All the caregivers attended antenatal clinic as required, and they had the routine investigations done. As according to F7, who was 27 years, I quote verbatim, I attended clinics from the 3rd month into the pregnancy. I was given a tetanus shot, my blood pressure was checked, and my blood test to show my blood group was done. Then another sub-theme from the normal pregnancy was no complications, normal blood works. Meaning there were minimal anomalies were detected antenatally, and most of the caregivers had no complications. As quoted by F20, who was 21 years old, she said, I had an ultrasound done and it did not indicate any abnormality. Also from F21, I quote, my pregnancy period was normal with no complications during the early stages. This continuation, there was information sharing, whereby the meaning was the diagnosis was made, but there was lack of information or there was no counseling. So most of the clients, some of them had only one had diagnosis made. So there was diagnosis of gastroschisis was made at delivery. That is what they were talking about, information sharing. So as quoted by F11, who was 33 years old, she said, I was not given any counseling by the county hospital after they told me about the baby's condition. One of the nurses assured me that the baby will be okay as soon as surgery is done. Then another one said there was delayed referral. Majority of the mothers were referred after delivery, leading to complications of management of the condition. This was quoted by F18, who is 26 years. Soon as the doctor noticed that my unborn baby had complications, they advised me to go to a bigger health facility when they back home. Then we have the trauma symptoms, that is objective number 2, whereby we were to explore the nature of trauma symptom exhibited by caregivers whose neonates are admitted in KNH with gastroschisis. one of the things that came up were they went through the stages of grieving. That means they were immediately after delivery, they went into shock, denial, anger, bargaining, depression, and acceptance. That means the delivery of the neonate caused confusion and shock to the mothers, leading to denial and a sense of unworthiness. As quoted by F1, who is 24 years old, said, I was shocked when I learned about my baby's condition, and I felt confused. I wanted to hide the condition from my husband until after all surgeries. The father was concerned about the baby. Then F14, who was 27 years, verbatim, I shared the information with my husband, who was shocked. Then the trauma symptom, the mental health issues came up as a theme, whereby there was emotional effect, and guilt. So mothers were saddened on seeing their newborns. They felt helpless. As quoted by F4, who was 24 years old, she says, I was traumatized by the situation since I had never experienced something like this before. There was also the aspect of stigma and spouse support. That means some mothers got support from their spouses, though they kept it secret from other people to avoid stigmatization. F21 was 23 years, verbatim, I asked my husband and mother not to tell our neighbors that I was admitted in hospital because I did not want them to visit me in the hospital until corrective surgery was done. On the mental health issues, there was also the issue of the family reaction. That means close family members gave emotional support to the mothers. As quoted by F5, who was 23 years old, my mother emotionally supported me from the moment we learned of the baby's condition. She was also okay with the referral since we were certain we would get quality care at KNH. I was shocked when I was told that my baby's condition could not be dealt with in the first hospital. Another aspect on the mental health issue is that there was health information, the aspect of health information and counseling. There was no counseling given to alleviate anxiety. As quoted by F11, who was 33 years old, was not given any counseling by the county level 4 hospital medical staff after they told me about the baby's condition. One of the nurses assured me that the baby will be okay as soon as surgery is done at KNH. Then my objective number 3 on the support needed needed by the caregivers who have neonates who are diagnosed with gastroschisis and are admitted at KNH. One of the things that came up was the support system. That is the support system, we had the family and the peer support. That means close family members gave support. The mothers admitted in NICU also supported each other. As quoted by F12, who is 20 years old. Verbatim, my husband has since taken over my responsibilities at home. He's taking care of our other children. I got courage by other mothers in the world as we prayed together for our babies. Then there is also the sub-theme of a sense of hope. That means the caregivers received support from the medical staff, giving them a sense of hope. As quoted by F15, who was 31 years old. The staff in the department are very nice. The nurses are supportive and give reassurance at all times. The doctors are also very good to me. I'm satisfied with the kind of care I receive here at KNH. Then we had another theme on the hospital environment and the relationship. Some of the things that came up is that there was negative and positive relationship between the caregivers and the hospital workers. The healthcare providers at the periphery were not keen and so they delegated their duties, leading to the loss of direction. At the same time, there was a positive relationship in the receiving hospital. That is, now they were sharing their experience at the peripheral level and whatever happened between the peripheral and the referral hospital. Then one quotes that while in the level 4 hospital at the time of delivery, the doctors around had delegated their work to student nurses and did not know how to handle the situation. While at KNH, I have gotten adequate emotional support from the medical personnel. Then the physical space infrastructure. The mothers felt that the physical infrastructure was not therapeutic. Then the hospital needs to increase bed capacity since we sometimes have to share beds, which is uncomfortable, as quoted by F7, who was 27 years. So the discussion, the one was normal pregnancy. So they study found that the mothers were excited to have conceived and they were expecting healthy babies. Additionally, most women had not noted any complications from their pregnancy and were comfortable with the pregnancy. And this was similar to the study conducted by the Center for Disease Control and Prevention. On the theme 2 on information sharing, the study found that there was late diagnosis and late information on the condition. No counseling was done despite the magnitude of the problem by the health practitioners, which is similar to the study conducted by Dekel, Stoop, and Disney in 2017. Then the theme 3 stages of grief, the caregiver went through shock, denial, anger, bargaining, depression, and acceptance, according to the findings in this study, which is similar to the study conducted by Kidane, which was done in 2022. Then the theme on mental health issues. They are similar to the other findings by Kidame 2022. This study found that the caregivers exhibited symptoms of mental challenges, for example, insomnia. Then the theme 5 on the support system, contrary to other studies where caregivers with neonates with congenital anomalies are stigmatized, according to Kidane 2022, the findings in this study showed that the spouses and close family members gave support. They also got peer support among themselves. This gave the caregivers a sense of hope. Then on the theme 6 on the hospital environment, the study found that the hospital staffs were friendly and gave information to caregivers, which was positive. This is similar to other studies conducted by Semis 2019, where care given to neonates was satisfactory. In conclusion, based on the result showed that prenatal experiences of mothers with neonates with gastroschisis was positive, and majority of them were happy and that they were pregnant and were ready to follow doctors' guidelines throughout the period. During the antenatal care, the diagnosis was not detected. However, postnatally, the caregivers experienced shock and suffered depression due to inadequate support from close family members and inadequate information about the condition before their children were born. They too were unprepared to deal with the stress and difficulties related to children's disease. 70% of the mothers, that is 18 out of the 25, received support from family members and their peers who had similar experiences. Recommendation: a more thorough prenatal screening is recommended to assist in the early detection of such congenital disorders, which can direct birth preparations for the mother and child. World Health Organization recommends at least one ultrasound during the first trimester. Healthcare provider also should consider the mental health of the caregivers with neonates born with congenital anomalies, other than concentrating on the neonates alone. Another recommendation: to assist in easing the mental and emotional strain placed on parents, hospital staff should provide professional counseling. They should also encourage peer counseling from among caregivers. And these are my references. Thank you so much.
Thank you, Rosemary. That is quite an interesting area of nursing research. I hope we are not in shock. especially looking at the condition. Though very rare as she started off, but with very significant outcomes. And especially when you compare the differences between survival rate in the first world, the developed world, and our local context. It is like double. That there is the survival rate abroad is over 90%, and locally it's just about 45 or so thereabout. So that is something that is important because it shows that with improved practice based on this evidence, then we can increase our survival rate for these neonates. And that is why we are going through such series. We are looking at how do we optimize the patient's experience. That yes, they have this condition, but can we get the best survival rates we can for these children? Hence the reason why we share these findings as shared by one of us, Rosemary here. Now we are ready and available for questions and comments and any other input that may be available from your end. It's now open for discussion. Feel free to lift up your hand. We will be able to see and give you opportunity. I don't seem to see the chat box from where I am to just see whether I have questions in there so far. But I appreciate that I have seen emojis. Some of them were shocked in my interpretation. A number of them were thumbs up and hand claps for the good research. And I believe we are together as we do. Thank you. I still acknowledge that we are happy to have had this presentation. It's quite informative. So I have a question I will be first to ask. And my question is on, I looked at the recommendations. And one of our recommendations, Rosemary, is that we do thorough prenatal screening. I would like you to take a few minutes as you answer even the other questions to tell us a bit about, are there risk factors or what we are calling thorough screening? What would guide thorough screening? Considering the fact that clients, the antenatal clients would attend and seek services at various levels of healthcare service provision. And therefore, what is thorough screening in level 6 may be different from thorough screening in level 3, for example. So what then would guide somebody to say, this is thorough screening in level 3, and this is thorough screening in level 6? Maybe risk factors would help, but I don't know. You will tell us more. Thank you. That's my question. Any other question in the chat box? If there isn't any. Okay. I see some comments there. Yes, I am seeing a comment on CPD points. This we will talk about it at the end of this presentation. Just attend, that is your role. The rest is us, will guide you. Then there is anonymous attendee. But first and foremost, thank you for attending, though anonymously. The question is, how is the prognosis of gastroschisis? I call it gastroschisis. I don't know how you pronounce it. But now we have been educated more on this very rare congenital malformation. So that is, I think Rosemary will be able to answer that. Rose Jerobe, thank you for attending. And even your input, she's asking, do you have counselors available for these parents? And at what point do they counsel the parents? Good question, very objective. Do we have, because clearly from your presentation in the findings, there was need for counseling, especially at the time of delivery, because these mothers get into shock and they need a support system. Then I also appreciate Anton Nkai, who says this was very informative study in our own context. I believe the more cases are undetected, considering that skilled deliveries, or I think the sentence should be, I believe there are more cases undetected, considering that skilled deliveries coverage is about 63%. There is need for community sensitization. Of course, I agree, but I know Rosemary will give us the expert opinion that yes, skilled delivery coverage is not 100%. And therefore, even as we talk about undetected cases, we would like to see how then do we help the community in this. I think those are very, very important concerns and comments. We will allow Rosemary to take up and answer some of them for a start as we continue to take more questions from your end. Thank you, Rosemary.
Thank you so much. Been asked to comment on the aspect of the recommendation on thorough screening. I thought somebody would ask also why, from my presentation, if you have noted, there were 6 mothers who had an ultrasound done and only one was detected. Yet the recommendation is that, according to the World Health Organization, you should have an ultrasound at the gestation of 12 weeks. So it means when I talk of that as screening, it means if we are going to do that ultrasound, we need to have it done by people who are qualified. Because one thing, I never put it in my findings because it was not part of my objective. But I was wondering, but I realized that chances are the people who are doing the screening, the ultrasound, either they are not trained to do ultrasound, and that is why they are not able to detect the anomalies. Because according to the World Health Standards, at 12 weeks gestation, we are not supposed to miss that. And when if we can have the ultrasound done by people who are qualified and they detect it, then I talked about informed preparation. Informed preparation as in, if you go to the studies on gastroschisis, you'll find that in developed countries, we have about over 95% survival rate. And what I can say, the management of gastroschisis mostly has to do with the birth preparations, unless the neonate will be born with other complications. With good detection, with RS screening, that is data screening, whereby we are going to detect it at the 12 weeks, we are able to inform the mother and prepare for delivery, whereby the recommendation is they should deliver in a hospital where they will be done planned cesarean section, and immediately the neonate is born, unless there will be other complications, the neonate should have the abdominal contents put inside and stitching done, and we are able to save the neonate. So birth preparation screening will inform on birth preparation. Another thing that has come up is that I have talked about, it's like with every year we are having an increase in these cases of anomalies. I have not done any research, but chances are, from my assumption, could have been even the issue of the diet could be contributing, whereby the kind of diet you are taking is affecting our children, for those mothers who are conceiving. It could be a factor, and we need somebody to research on that. The other one has asked about whether we have counselors for these mothers. I can say yes, we have. In Montfoy, we have mothers. We have a counselor who takes care of these mothers, and depending on the extent of the gastroschisis, we are able to counsel. They also do something we call family conference, and sometimes they call me to talk to the mothers about the condition. So we have taken a step. Counseling is being done. We are doing family conferences. Somebody had asked about the prognosis of gastroschisis. The prognosis should be above 90% with good birth preparation. From my presentation, I said they come with dehydration and they come with sepsis. So by the time a unit is referred from a county, maybe from Meru, by the time they are getting to KNH, maybe they have stayed for 2 days. And if you, with gastroschisis, when abdominal contents are exposed to free oxygen molecule, the literature dictates that we should have the content put back within in a maximum of 45 minutes. So it's like when we detect gastroschisis antenatally, we are supposed to handle them the way we handle patients when we are doing kidney transplant, whereby the mother will have the cesarean section, the neonate is removed, and then the neonate also is taken to another theater, and the contents are returned, and the stitching is done, then the whip will heal. And without, if there are no other underlying complication, we should not lose that unit. So survival rate, that is why in the study, in developed countries, they are not losing units with gastroschisis. Survival rate is above 90 because of that bad preparedness. That is key. I hope I have answered your questions.
Thank you. You have done justice to these questions, and clearly you have even thrown in a challenge that we need to take up a research area as a recommendation to further explore on the risk factors for this condition, to build on the knowledge that is already existing. So I think so far so good. Let us also have a few more questions. The question by Charles KNH. Charles, thank you for attending and participating actively. He is asking what's the immediate care in the periphery. I believe periphery refers to the lower level facilities in the referral system in Kenya. I don't know how low it can be, but probably in your conversation, Rosemary, you tell us from your experience, where are these patients coming from? And yes, if this happens in the periphery, what should they do? So that by the time we are getting this unit, we don't have the extreme side of dehydration or infection. Then the other comment, the other question is Winfred Kimani. Thank you, Winfred, for attending. And Winfred is acknowledging that, Rosemary, this is great work. And I do agree with Winfred. This is really very informative. Yes, thank you, Winfred, for that comment. Yes, anonymous attendee, again, another one, still acknowledging that this is a great presentation. Indeed, it is. And this tells you that knowledge sharing is very, very important in nursing. And let's keep up this good work, Rosemary. And any other person who is doing research, we are here as Nursing Standards to support you, to collaborate so that we are able to empower one another. Now, Rebecca Mushiri, thank you for attending. Rebecca is saying, are there preventive measures such as in neurotubal defects? Preventive measures. How do we prevent this? That is something Rosemary may want to also educate us more on that. I don't know. Rachel Muya is saying something here. It's not very clear. Rachel, thank you, Rachel, for attending. Rachel says, very well presented. Congratulations, Sana. I had no knowledge about the condition, but now I have. Yes, Rachel, this is just the beginning, and then there'll be more to it. Probably take it up as a research study and you can learn more. Christopher Bosire also attending. Thank you for attending and participating. Requesting to have the slides shared. Guidance will be given on how the slides are usually uploaded in this particular webinar series. So far, so good. We have good number of questions, I think, for you to educate us more. What the audience is communicating, in my perception, is that this is a very important area, and we have just opened it up, and now we are eager to learn more. So as you tackle each and every question, also help us learn any other related aspects. So far, so good. We can, Rosemary, you can take up those few questions and then we continue. Keep sending them. I still appreciate the thumbs up. We are silently acknowledging that this is a great work. Rosemary, to you.
Thank you so much. Somebody has asked about the immediate care in the periphery. I want to emphasize on, if you detect that there is an anomaly, kindly prepare the mother to deliver in a hospital where they can have cesarean section done, and the corrective surgeries can be done. I said the corrective surgery should be done with a maximum within 30 to 45 minutes. Because when we expose the contents, they react to free oxygen molecules, there will be swelling. When there is swelling of the abdominal contents, if you try to fix them, of course they will not fit. Even if you take the unit to theater, you have complications because the contents will not fit in the abdomen. That is why we are told they should be exposed for a maximum of 45 minutes. So at the periphery, if you are in a place where you can save the situation, the immediate care is, if you have a urine bag, you can use the urine bag. You tear the urine bag and you make sure it's like you cover the wound with the urine bag. You cut the urine bag, then you cover the abdominal contents with the urine bag, even as you prepare for referral. The other thing, you should ensure that maybe there is IV access. Because of that exposure of the contents to free oxygen, there is the aspect of dehydration. So you make sure that the neonate is put on IV fluids, which might be a bit challenging in the peripheral, but with a urine bag, you can cover the abdominal contents even as you plan for referral. Don't use gauze, just use the urine bag, because inside the urine bag, that bag is usually sterile and clean as you refer the patient for further management. Thank you. About the preventive measures, we talked about early screening during antenatal period. And defined during antenatal periods, there are some medications we give to the mothers, especially the folic acid. Many of the anomalies has to do with the deficient of folic in the early development of the neonate, that is the newborn in the utero. So we need to encourage, when we are taking care of mothers antenatally, we need to take care of these supplements. They are key, especially we can even have them take they can even take the supplements even a few months before they conceive. We are able to prevent such anomalies.
Thank you. I think you have answered quite a number of those questions. Should there be any that has not been addressed, we will still look into it. But yeah, I have an interesting observation. Nursing and innovation. This is great. I'm hearing the urine bag. Yeah, that's quite an innovation. Probably something to just talk about after this presentation and laugh about it. But I find it very, very interesting. That is what is within, it's about just achieving the same objective, preventing infections, but using what is available, the available resources. And I think a urine bag is available at most levels of care. And that is quite informative. Well, forgive me for asking questions. One question I am asking is, all our antenatal clients, attendance of the clinics is 100%. Now, it's interesting to note that only 1 out of the 5, only 5 had an ultrasound. That tells you that as per the discussion you've had, every mother needs an ultrasound. So again, that is something to open our mind and see why the difference. And even among the 6 who had an ultrasound, detection rate is 1 out of the 6. Again, if there's anything that we can understand why it is so low, so that we do something. The reason we do research and share findings is so that we improve the practice. And that's why we have to critically look at the findings and see what can we do differently based on the research findings and improve our outcomes. But let me allow the other questions to be answered. I see an acknowledgement of this particular work. Rose Njoroge again, and she says, and thanks Rose for your engagement, that was a unique research condition in pediatric surgery. Yes, it is. And a great presentation. And Rosemary, you can tell congratulations to you for the good work. Keep it up, I say. Then Odenoke, I may not pronounce your name very well, but thank you for participating. You also acknowledging that it's a great presentation. I see, yes, Lillian Sabila has a different question. This is different from today's topic. Probably we will take it up next time, but it says, what happened with hydrocephalus cases at birth? Here, that's quite another area. So I wouldn't want to load it onto this particular presentation, but I'll take note of it and we can explore how we get another session for such. Unless in Rosemary's knowledge, there's a relationship between, which I doubt, and therefore let's reserve this question for its own time so that we give it due justice. Sheila Nafuna is saying, thank you so much for this knowledge, I appreciate. Yes, we also are happy to have you here with us. And what is the rationale of using the urine bag? I think that's an interesting innovation. And I know, so I'll give you a minute later to answer that, because this is scientific research is scientific, so you must give rationale for why the urine bag. And I think she mentioned, probably you didn't hear, Antonin Kai during the study, was there areas or regions showing higher prevalences? Actually, Anthony has asked the question that was in my mind. As an epidemiologist, you want to see, are there trends? So that as even we say that community sensitization is one of our recommendations. Is this community sensitization targeted, or is it, what approach does it take then? So are there areas that have shown higher prevalence with regard to this condition? That would be something for us to learn. Any alternative for the urine bag? Yes, people are exploring any alternatives. So yes, good questions there. Rosemary, I think you can respond to this. And I like this conversation. Very educative, very engaging, very informative. Thank you.
Thank you so much. We've talked about the aspect of the ultrasound. From my presentation, only 6 of the mothers were able to do the ultrasound. What we can do maybe is that we need to recommend, why the rest never had the ultrasound is because most of our institutions do not have ultrasound services. Sometimes their mothers from the periphery, they asked to do it from outside. And the cost of the ultrasound, from what I heard, it was about 1,500 shillings, which is quite a lot of money to some of the clients. So my recommendation, though it is not part of this, I wish that we could make an ultrasound affordable to all expectant mothers, so that we are able to have the test done, not not only for those who have the money and can afford. What came up during my research, and I feel I'm challenging us, we can also research, is why did they not detect that there was an anomaly? Either the people who are doing ultrasound in those private clinics are not trained, or we have a problem with the training of our radiographers. So that is an area that needs to be researched on. Somebody has asked why use a urine bag. I've talked of using a urine bag because that is what is within us, and it is clean. We are trying to minimize sepsis because these are abdominal contents. So I have just used what is available in the hospital setup, and that is why we are talking about a urine bag. I don't have any other alternative, but in cases where you don't have a urine bag, then you can cover the area with gauze. So it may not be practical for you to have warm saline, you pour on the contents, you make sure the gauze is warm until you get to the area of your referral. But if you can use warm saline, you make sure the gauze remains warm to make sure there is circulation of the abdominal contents, even as you transport the patient to the next level for further management. Somebody has asked about whether we have specific areas where this is, where gastroschisis is preference. From the study, we get people from every county. So we cannot say that it is prevalent in this particular area. But we noted, though there is no documentation, there's no research to prove what I'm saying, but from experience from 1.4a, we have realized that gastroschisis is seasonal. We have specific months when we are getting neonates who have gastroschisis. So for now, I cannot tell you the relationship between the time of the year and the births of gastroschisis. But we realize from around March, April, we are getting neonates with gastroschisis. So this is an area that also needs somebody to research on. Thank you.
Wow, very, very interesting conversation, very informative. And we really want to get practical about the evidence that we are presenting and the recommendations that we are making. Hence the reason why participants are interested in knowing the rationale and what works. And yes, now Grace seems to also add into the question to try and answer why the not out of 6 only 1 is detected, and she attributes it to probably a staffing shortage in a department. We can only recommend that some research, some evidence will be required for that particular kind of conversation. Gentrix Wamasi, good presentation. Thank you so much, Gentrix. We are here to educate each other in nursing and to improve practice through research. Is the urine bag secured by sutures or just applied and secured in place by gauzes? That's something interesting. And yes, we will learn more and more about any innovation that is working. We are here to learn. And Odenoke says ultrasound in our facility is 800 Kenyan shillings. I want to assume so. Oh yes, but interestingly, that may be not within reach of 100% of our population. It's a reality. So again, we need to look at into how can we inform healthcare financing for reproductive health services, especially where we see that this is really an important aspect. And this is where we take it in terms of nursing advocacy as a role, because the need here is the financing of the service that will help us detect this condition and make a difference in the care, the preparation, what she called birth preparation. It makes a difference. So, and it increases the survival rate. So healthcare financing is what we need to advocate for all mothers, in my view. Yes, I think someone had asked about prognosis. I missed that question. I don't know whether you addressed it, but if it wasn't addressed, you could address it again. But prognosis, yes, you talk about it. Those few remaining questions, you can take them up. We still have time, and it was time to learn about gastroschisis. But participants, I also want us to also take our focus to the topic of the study today. The main topic was the caregiver. Okay, so let's also engage more on the caregiver. We are also here to actually ensure the caregiver gets the optimum support. Yes, I agree. So far, the questions you are asking on the condition are also going to ultimately influence preparation of the caregiver. So we are not lost, but let's also keep asking many questions on the caregiver's experiences. What can make it different? I also have a question I'll ask at the end. Let's hear from Rosemary.
Okay. Prognosis of gastroschisis, I think I had missed that. When I started doing my research, the reason why I picked up this topic, I started doing the research in 2019. By then, the survival rate in our nation, it was 5%. So it tells you the prognosis was not good because mortality rate was at over 95%. So now prognosis, as we talk now, there is a lot of improvement in Kenya because now our survival rate we have gone up to 45.3%. The reason being, when we get these neonates on time, we are able to improve on the dehydration. We minimize sepsis by application of silo bag in theater. That one is done, and then we do it the way we treat the fractures, whereby a silo bag is put and it's like they're on traction. You keep on reducing as the gastroschisis shrinks until finally with the abdominal contents are able to fit, and then we can do secondary suturing, and then we can save the neonate. So as a nation, we have improved because from survival rate of 5%, we are now doing 45.3%. That means if the radiographers will detect this thing on time, we can have over 90% of survival rate because there will be proper birth preparation, and so we'll be able to salvage the situation. So prognosis as per now, we can say that it is fair. We are heading somewhere, and with good antenatal care, we can go up to 90% like other nations. Thank you.
Thank you, Rosemary. Clearly, birth preparation is key in addressing issues of prognosis as a result of the survival rate. And that's very, very important. Yes, and I said I'll ask a question at the end, and the question will be very, very interesting. Now, this condition takes a toll on the caregiver, the mother. The primary caregiver is the mother. did you at any point get to interact with the secondary caregiver, the father? Because in the picture you could see that some spouses initially were hesitant to include the spouse, the husband, but others included them. Peer support was also key. That is something that we need to encourage, in my view. Peer support. What works should be encouraged. Family support should be explored. What are your comments? Even as I end with asking, at some point it came out that there was no counseling at birth. That's a concern, but we have just acknowledged that now we have counselors. So at the time of the study, there was no counseling. Maybe you'll clarify. Let me not put words into your mouth. What is the situation today?
Yeah, thank you so much. During my presentation from the themes, I talked about lack of information. This came out very clearly at the peripheral level, whereby when the neonates were born, it's like the staff just told the parents, you go for surgery, and that was it. So according to the mothers, the sight of the Gastroschisis itself is very discouraging and traumatizing, and no information. Unlike one mother who said she was given counseling at the peripheral level, and she was assured that once you get to KNH, all will be well. So at the peripheral level, I think we also need to do a bit of counseling. Let's have time and talk to the clients, because it is therapeutic, so that they are able to adjust to whatever they are going through. The other thing, I've been asked whether I came across a father. In the course of my research, yes, I came across one of the fathers, though he was not among the respondents, but his experience, according to him, it was very shocking, and he did not understand why there was such an anomaly. So according to the father, he felt that this is something to do with the wife from her family side. It's like, from our families, we don't have such. So it's like, it's from my wife. But we had a family therapy in the ward, the counselor, plus the ward in charge in NICU, and they also incorporated me. We had a family conference, and we talked about Gastroschisis, and we reassured the father. So support is very key, because when a mother delivers a child with an anomaly, most of the trauma they go through is because they are told these abnormalities are from your generation, not from my side. So you find this is a mother who has just delivered. You know the stress that goes together with pregnancy. After delivery, you are supposed to recover, but instead of you recovering and breastfeeding your child, you are admitted maybe with a fresh scar in a ward. So you are not taking care of another patient. You yourself, you are a patient. So you have not even rested. You have just gone through labor. So it is very stressful to the mothers. So on top of that, then you get relatives who are wondering why you have given a child with an anomaly, and in their family, they don't have such. You can see where the situations some of our clients are. So we need to have counseling as part of treatment. We need to plan the way we plan for medication. I know there are some people in the medical field who don't take counseling as serious. Sometimes we underrate what our counselors are doing. But most of the times, if we had counselors, some of the treatment we are giving in terms of medication will not be needed. You will talk with these people and they will feel relief. They will tell you they not even need the medication. So counseling is key for us to support them. I talked about peer support. Among my clients, we had very young mothers. Some were school dropouts. So they were, every time we were trying to talk to them, they were breaking down. But after talking with them, it's like they felt like somebody cares. I'm not the only one. I remember introducing one girl to another lady who was a bit mature, And I told her, you can talk with this one. She's also going through what you are going through. And it's like now they are able to exchange notes and they are able to work together because they have something in common. So counseling is very important. As medical people, you may not do anything at the peripheral, but you can talk to these clients, you can talk to this family, even as you refer them for further management.
Thank you, Rosemary. We continue to learn, and there is no monopoly of knowledge. So I appreciate when Susan Waweru, maybe a suggestion, let's also emphasize more on community midwifery and mothers to be encouraged more on diet or supplements to antenatal mothers. I am a midwife working in OBS guide. Yes, we need to collaborate further because this is not just one aspect. The midwives are involved, they have a role to play. The pediatric nurses have a role to play, and we all work as a team, and we can make it better for the patient. Nyakundi is still appreciating the knowledge. We acknowledge your comments, and I want to see this one by Anthony Kai, hopefully the last comment. Yes, Anthony says, are there preventive measures for the condition? Have we tackled this?
Yeah,
We have. Oh, yes, yes, we have tackled this. Thank you. Then I think I feel we have captured everything, but I'm just amused at the Nwoke's comment that the facility charges 800 shillings, and I'm specify. He has specified the facility in Kitale, and we are saying that is good, let the clients benefit, but should there be any who is not able to reach this service financially, it's time we advocate for its inclusion in our basic care packages for reproductive health services. Okay, so again, parting shot from my end seems to be like counseling should be as taken as prescribed, because I know we do prescribe counseling. It is prescribed. So then it should be administered as per prescription. That is what I take home from this particular session. I wanted to say that we are joined with Sharon. She has been here with us. I want her to say hi and say something. Thank you, Sharon. Karibu sana.
Thank you, Madam Nancy Kera. And thank you, Rosemary, for the presentation, which was very good and very timely. I must say that gastroschisis is a condition which is quite traumatizing to the mothers who get these babies with this condition. And of late, we've been experiencing a lot of them coming in. And so it is something that really needs to be researched on, and we need more knowledge on this. And so the job that Rosemary has done is very commendable. And we encourage nurses to continue doing research, to continue giving more information and more knowledge. Because as KNH, we are a teaching and referral hospital, and whatever information that comes from here also contributes to the national policy. We give a lot of information that is used out there for preventative care and also for curative care. So with the information that we have received today, it is information that is very useful to the community, whereby the mothers who are conceiving children there, they need this information because they need to understand that the care they get during pregnancy and even before conception is very important in the outcome of their pregnancies. So the information that we've gotten today is very important to be spread out there so that the mothers get to know this. Nurses, we should continue doing more research, and we should continue giving out the information as is required. Most of the time we concentrate on the neonates who are our patients, because in our level 4, Ward 4A in particular, we have the neonates who are our patients and the babies who are our patients, the patients with gastroschisis. So you may find that our care is more concentrated on the babies that are admitted in our wards. And sometimes you overlook and we forget that the mothers who are the caregivers are also more of patients as they are going through this. Some of them are never prepared for this, as research has just indicated that some of them don't even know that they're expecting this kind of baby. So when they get these babies is when they get the trauma out of it. So it is important that even as we take care of these babies, we also look at the caregivers, look at the mothers. What are they going through? What kind of care do they need? And this research is actually bringing out these issues, and it is something that we really need to look into. So it is a very timely research. It is very important. And thank you for this presentation, Rose. We continue to encourage. Actually, she has mentioned that there are still opportunities for more research when it comes to this area, because we have not been told more of the causes, probably, whatever could be causing this condition. So there's still opportunity for research. Let us get into more research and let us give more knowledge as we do our work. Thank you.
Thank you, Madam Sharon, for that insight into this particular topic. And we appreciate your support in all this since the inception of the study, throughout the study period, and even up to dissemination of the results. We are happy again to collaborate, and I speak on behalf of nursing standards specifically, but also on behalf of our leadership in nursing that supports nursing research across the hospital. Now, I want to say I would like to bring this conversation to a close with a few remarks from nursing standards. Then I will allow our technical person to give us some guidance concerning any technical or administrative issues that have been raised in the session. One, we want to say that Nursing Series is a nurses platform. It is available for us as nurses in KNH and globally, but Nursing Series specifically provides the KNH nursing team with a platform to enlighten one another and to just grow and gain knowledge. And through our practice, sharing the research findings, any knowledge that you're sharing, this platform is available for us. It is usually every first and last Thursday of the month. And you can diarize this. Let's plan better as a team so that we are able to attend. I know we have a myriad priorities, especially in patient care, the practice part, but we can prioritize and plan better and create some time, 1.5 hours in your 1 week, the first week of the month and the last week of the month, usually on Thursdays, except for today, for some special circumstances, we have held it on a Friday. So look out for it and encourage our nurses and our teams to attend. Just as we have acknowledged, we have learned so much, and therefore we believe that you will learn by attending these sessions. I think the CPD, yes, I want to acknowledge the teamwork from the nursing standards team. Mr. Kuisok is not present here, but he's our leader and has been guiding us in this particular process. We at Nursing Standards are responsible for coordinating continuing professional development for nurses within KNH. And we are happy to support every CPD activity, whether it is this webinar or a physical one in your workstations. Our office is on 6th floor between Ward 6A and 6B. We are available and we are working this is just one of the things that we do. Of course, we do other functions, but we are fully available to work with the nursing team in whichever aspect. And therefore, feel free to walk in. We are an open door policy office. We will be happy to support one another and share knowledge. So I want to thank all the participants who are present, that you made time, you created time to be here to learn and even to share your knowledge. We are very grateful. It actually enriches the whole experience of this webinar session. And we look forward to seeing you. And we urge you next season, tag along someone whom you think will benefit from this. Send a reminder on the morning like today and say, hey, this is happening today. You'll be happy that you've also contributed to sharing this knowledge. So asanteni sana. CPD points, Nelson, thank you for your support. We are indebted to your support and we appreciate. Please tell us a little bit about CPD points, because I don't know whether this is the only nursing audience. I believe there is beyond nursing audience, and the different strategies and approaches to CPD apply.
To our participants, as communicated in your reminder emails and also on our registration portals, CPDs are awarded according to your regulatory body, so the process may not be the same, but rest assured that once attended, the attendances are generated, and those who qualify for CPD points will be awarded the CPD points for those sessions that they have attended. So if you have a question or you may have just an extra query, you can always email us at knh@knh.or.ke with your queries, and our support team will be able to answer your questions regarding the CPDs. But for information, you can always have a look at our registration page or your reminder emails for the different instructions as per your regulatory body. For the notes for this session, kindly note that the recording will be uploaded to our YouTube page, which is at KNH Research. We normally update the sessions after they are done, so you can visit our YouTube page, not only this nursing series or rather this session for today, the past ones have also been uploaded to our page, and you can always revisit for your reference. Thank you.
Okay, thank you so much for that clarification. And I know for you to get the CPD points for nursing, and I think for everyone, you needed to have attended this session for over 30 minutes.
Yes.
Oh yes, that's important for us to note even going forward. My able presenter, asante sana for sharing your knowledge. We look forward to even hearing more from you, and we wish you well as you pursue your PhD. Madam Sharon, thank you for the support. We are looking forward to hearing something on hydrocephalus. It may come from your department at some point in the future. We will continue to learn more. So that is something. Yes, Rosemary has a parting shot or something to just say. It is okay. We are still within our time. Thank you.
Thank you so much. For those who want to read further, this work I've already published in this journal, International Academic Journal of Health, Medicine and Nursing. I've written volume 1 and volume 2. So you just go to the Web of Science, you Google Gastroschisis, you get my work are there. Thank you.
Wow, that one, she deserves a clap. And if you are there, send the claps to this particular researcher for today. It's a published work, and therefore it is something that even the peers have said is worth sharing. Thank you so much for that update. You can see the claps there for that kind of work. So yes, nurses, we are doing well, not just in one area of practice, but in all areas, including nursing research. I wish to end today's session by saying thank you so much to everyone who made this possible. And I thank God for the privilege for us to share knowledge. Let's keep sharing knowledge. Let's keep giving our patients the best, and the best will come from evidence-based practices. Thank you so much. Have a good evening.
Let's go back. Yeah.